Okay, welcome to the IPDLN 2020. This is the linkage techniques and issues session. My name is Simon Thompson from UKCERP and Sale Data Bank in Wales, and I will be the chair of this session. In the session, there'll be 4 times 10-minute presentations from our speakers, and there'll be an opportunity for 15 minutes questions and answers at the end after all 4 speakers have been. If you have any questions for the speakers, then please use the Q&A function, which is in the portal, should be to the right-hand side of the video window. And after the speakers have presented their topic, we'll come back and we'll pick questions from the Q&A section and allow us to have a bit more of an interactive session. So it is with great delight that I introduce Kelly as the first speaker. So Kelly is a research fellow within UKCRC, Public Health Centre of Excellence for the Department of for the Development and Education of Complex Interventions for Public Health Improvement at Cardiff University. The substantial focus of her research is the improvement of the health and well-being of children and young people. Kelly is particularly interested in the development and evaluation of complex interventions, drawing on her mixed methods experience and her broad experience of using routine data. So Kelly, would you like to take the floor, please?
Thanks so much, Simon. Thank you ever so much for having me today, everyone. It's great to speak to you this morning. So as Simon said, I'm Kelly, and today I'd like to present to you findings which concern sources of bias when we combined routine data with a national survey of secondary school aged children. So this study is based in Wales in the United Kingdom. So over on the left is one of our glorious beaches, if you were to visit on a sunny day. And here on the right is where the research was carried out, so at Cardiff University. And it was in collaboration also with Swansea University. And the study concerns data linkage. So here we are talking about a process of pairing records from 2 files, so particularly a student, and trying to collect the pairs which belong to that same student within the school setting. As I'm sure we're all aware, there's a number of growing international infrastructures to facilitate data linkage. And we know that there are many benefits in terms of the access to population data at that high level of granularity. So thinking about at the individual level or at the household level, and it can really support longitudinal research and policy making decisions. However, there are a number of potential challenges in terms of data completeness and the quality of data, whether data is missing or whether data is missing because that participant didn't go and access a health service, for example. So in order to offset some of these limitations and to overcome self-report limitations with wider data, we wanted to look at combining routine data with self-report survey. So first of all, our study concerns the School Health Research Network, and that's a national cross-sectional survey of students across the whole of Wales. And this involves 11 to 16-year-olds, and the data was collected across 192 schools. And it was in 2017 for this particular presentation. So we gathered 3 levels of consent, whereby we have a school level, we have a parent opt-out, and we also have a student assent. And we embedded a pilot design, so all schools take part in the School Health Research Network biannual survey. But in 2017, we embedded a pilot design among 42 schools so that they had an enhanced survey which sought to collect personal identifiers to enable data linkage. So our study drew on the SAIL data bank, so the Secure Anonymised Information Linkage Data Bank, and this contains anonymised data about the population of Wales. So anonymised student health and wellbeing data were deposited within the data bank and subsequently linked to routine medical records So we accessed primary care data sets, a number of hospital data sets also. And with our linked data set, we were particularly interested in using multi-level logistic regression models so that we could compare characteristics between consenters and non-consenters. We wanted to look at characteristics of those who were successfully linked and those who were unsuccessfully linked. And thirdly, we wanted to examine our linked cohort with peers in the wider population of Wales to compare their mental health diagnoses and health service contacts, so we could have a look at the representation of our linked data set. So first of all, when we compared characteristics of consenters and non-consenters, as you can see, just at 0.15% of students were withdrawn from parents. And I've shown here the three kind of cohorts of schools. So we have our data linkage schools, schools who did not consent to data linkage, and then schools who were our control schools. So they had consented to data linkage, but they were randomized not to take part in the pilot. And what we saw was that there was little discernible effect at the parental withdrawal rates. So no bias was introduced at this particular stage. If we think about consenters and non-consenters, just under half of our population of students provided consent to linkage. There was little discernible effect of gender. However, we did note that as the children age, so in the higher school levels, there was a lower consent rate to linkage. And we also found substantial clustering at the school level. So schools with a higher affluence were more likely to consent to linkage, and that was regardless of any of the students' characteristics themselves. We found that students were more likely to consent if they reported positive mental well-being within their survey, and if their family affluence score also achieved a higher level. But there were a number of factors related to student self-reported health behaviours which showed lower consent rates. And we see this clustering here where students who reported weekly smoking, regular cannabis use, if they've ever truanted or been excluded from school, they were showing lower rates of consent to linkage. And this is something which mirrors wider studies when we're thinking about risk behaviour taking and consent to research. When we think about the students who we then successfully linked, so of those who consented, as you can see, just under 70% were successfully linked into the SAIL data bank. Again, though, we found no difference between boys and girls. We found that consistent finding whereby older children were less likely to be successfully linked. And now we found no effect of affluence on linkage success. In terms of the survey data gathered, there was one significant finding, and again, it was that trend that those students reporting a positive mental well-being were more likely to be successfully linked. And when we talk about successful linkage, from the students, we asked them to report their first name, surname, their date of birth, and their postcode. And that was the information that we required in order to provide the linkage. And finally, we wanted to compare students who had taken part in our survey and who had been successfully linked to the routine data with a wider population of young people. And these were young people of comparable age, and their records exist within the SAIL data bank. And for both of these cohorts, we wanted to compare whether each group had had any mental health diagnoses, We were also interested in whether they had a contact with a mental health specialty, whether there were any depression or anxiety diagnoses, and whether there were any reportings of self-harm. And the aim of this particular aspect of our study was to really have a look at that representation between the two groups. So as you can see here, the young people in the wider population had higher rates of all of the outcomes that we were having a look at. And that gives us a picture for how generalizable our results will be for any further analyses on this linked cohort. And really it gives us some insight into that need for accuracy and supporting that successful linkage of young people's data. So to conclude, we found no evidence that an introduction of consent to linkage had an impact on parental consent rates. However, we did find that there was bias at both the student consent level and at the school consent level with regards to demographics and those self-reported health behaviours. And we found further bias also related to the accuracy of the identifiable data provided. So all in all, there is a further need to better understand the decision-making processes around providing consent among adolescent populations. And this is work which we're continuing with now. We're repeating the process using our 2019 survey data, which includes a larger sample. So that draws me to the end of my presentation. So thanks ever so much for listening today and for the opportunity. I'd like to draw thanks to the wider research team shown here, to the funders, and to highlight that we do have a paper published on this presentation. And if you'd like to get in touch and hear more, please do. My email is provided here. But thank you ever so much for your time today.
Thank you very much, Kelly. Okay, very interesting talk. So if you could put your questions for Kelly in the Q&A section, that would be very much appreciated, and we can come back and ask Kelly some questions in a moment. So we move now on to our next speaker, Gill. Gill is a health and population data scientist and a UKRI Innovation Fellow, specializing in health geography and exploiting administrative data and data linkage. Her research interest is in the wider determinants of health, in particular, the effects of the household and individual level geography and the environment on health behaviors and outcomes. Kelly, if you could just unshare, that would be awesome. Oh, no, sorry, okay, we're brilliant. Okay, over to you, Jill. Thank you very much. Okay.
Sorry. Okay, so good morning. My name is Gill Harper, and thank you for the opportunity to present today. So address matching is a form of data linkage that can be used to assign unique property reference numbers, or UPRNs, to addresses. In this case, to general practitioner patient addresses held in electronic health records. UPRNs are of value because they provide a standard reference number for each address, which is more convenient than free text addresses. This means that the same address is easier to identify across patient records to identify when patients live together, for example, for household analysis of health behaviours and outcomes. The UPRN can also be used as a linking field to other data that contains UPRNs, for example, to local authority data, for data integration and whole systems purposes. Geographical coordinates are also available for UPRNs, which enables mapping and geographic analyses. So this functionality of UPRNs enables new spatially granular research questions. Accuracy and bias in address matching results applied to patient addresses is unknown. There's a lack of transparency in available software, and they tend to be black boxes. Therefore, the overall objective of this research was to transparently determine the accuracy and bias of address matching results applied to patient addresses. Specifically, by quality assuring a bespoke address matching algorithm called UPRN match designed by the Discovery Data Service in North East London and myself, using registered patient addresses that are routinely recorded in primary care electronic health records, in line with data linkage best practice reporting principles. This was for an ethnically diverse inner city population in North East London, which poses challenging address quality, and also to check for bias in the resulting matching success using patient demographic characteristics. So the study population was a cross-section of adults taken from the North East London Discovery Data Service database. This data service was set up to create a real-time information service for direct patient care, and on that basis can view identifiable information such as addresses. The data service run the address matching algorithm on the identifiable addresses and make the outputs available to approved researchers in an encrypted format. This valuable partnership enables innovative research. So the database contains primary care electronic health records for 2.3 million patients, currently registered with the 317 GP practices in North East London, showing in the purple boundary on this map. North East London is broken down into 7 clinical commissioning groups, or CCGs, which are more or less coterminous with the local government council geographic boundaries. So this particular study included 906,000 currently registered patients in the 4 inner North East London CCG areas, which are City and Hackney, Newham, Tower Hamlets and Waltham Forest, shown in orange on the map, who were aged 18 and over as of July 2018. Almost half this population are from Black and minority ethnic groups, and the majority, about 90%, are of working age and are all highly disadvantaged, as shown by living in the top 2 quintiles of deprivation using UKRI level deprivation indices. So our method was to run the algorithm consisting of 213 deterministic rules on the patient addresses of the 900,000 people in our cohort. These addresses were matched to Ordnance Survey's address-based premium database, which lists all addresses and their corresponding UPRNs in the UK. And the results from this were first of all reported on and quality assured using best practice reporting principles based on Gill, giving the overall match rate and calculating error rates by running the algorithm on a gold standard data set of 9,000 addresses in Wales. Binary logistic regression was then used to evaluate any bias in the results using adjusted odds ratios based on demographic and clinical patient characteristics from the data and the electronic health records. So our results, we found a match rate of 96%, that is 96% of the 900,000 patient addresses were assigned a UPRN. Data linkage reporting best practice was followed to calculate the error rates of sensitivity, specificity, positive predictive value and negative predictive value and the F measure by running the algorithm on the gold standard data set where the UPRNs were already assigned and checked so that results could be compared. Our gold standard data set was for 9,000 Welsh addresses, a challenging test for the algorithm due to differing address conventions and spellings. The error rates are shown in the table. So the high sensitivity and PPP values of 0.99 mean that our algorithm found the same UPRN as the gold standard for 99% of the 9,000 Welsh addresses, which is an excellent true match rate. The specificity of 0.8 means that our algorithm agreed with the gold standard in not finding a UPRN match for 80% of the Welsh addresses that also were not assigned a UPRN in the gold standard dataset. As such, our algorithm did find a UPRN for 20% of the Welsh addresses that the gold standard did not have a UPRN match for, which equates to 20% false positive rate. However, there were only 10 cases in the gold standard dataset that did not have a UPRN prior assigned, which is a small denominator. So our algorithm incorrectly found a UPRN for 20%, which is only 2 of these 10, so it's a very small number. The NPV of 0.13 means that of the 62 gold standard addresses our algorithm did not find a UPRN for, this agreed with the gold standard for 13% of them. The other 80% did have a UPR assigned to them in the gold standard dataset, which equates to an 87% false negative rate. Again, this denominator is a small number, and on manual checking, clear reasons for this error were found, due mainly to spelling issues, and this was used to inform subsequent algorithm improvements. Ferrante and Boyd in 2012 deemed that algorithms with an F measure greater than 0.8 are very good. And as you can see, our F measure of 0.99 surpasses that and indicates that our algorithm is exceptionally accurate overall. So in terms of bias in the match results, this graph shows the adjusted log odds of a UPRN being assigned based on complete case analysis, binary logistic regression using Stata with 95% confidence intervals. I'm only presenting the significant variables due to time constraints, and these are the patient's ethnicity, the patient's age when they registered with their GP, the patient's sex, if the area they live in is in the most or least deprived quintile in England, if the date they registered with their GP was in the most recent decile or otherwise, the number of current GP registrations they have, and the number of different addresses recorded for them across all their registrations over the last 12 months. So anything with an odds ratio of less than 1 on the left of the central bar is less likely to have their patient address successfully matched to UPRN by the algorithm compared to the reference group. And anything with an odds ratio greater than 1 on the right-hand side of the bar is more likely to have their patient address successfully matched to UPRN by the algorithm compared to the reference group. So I'll talk about the characteristics that are less likely to match first. These are if a patient is from most ethnic backgrounds when compared to the white ethnic group, if they were an adolescent aged 15 to 19 at registration with an odds ratio of 0.6, or if they were elderly aged 90 and over at time of registration with an odds ratio of 0.4, if they were male, an odds ratio of 0.9, and increasingly less likely with each decrease in deprivation quintile, culminating in an odds ratio of 0.3 for the very least deprived quintile compared to the most deprived. It's also increasingly less likely with increasing numbers of different patient addresses that the patient has in the last 12 months, suggesting a mobile transient population, and that's an odds ratio of 0.2 if they've got 3 or more addresses in the last 12 months. Then a UPRN is more likely to be assigned if a patient is from Bangladeshi ethnic background with an odds ratio of 1.8, increasingly more likely with every decile decrease in registration date, culminating in an odds ratio of 0.5 for the least recent decile compared to the most recent, if the patient has 2 or more current GP registrations, an odds ratio of 2, and the latter suggests a more complex population who are registering with more than one GP practice at the same time, and we're investigating these cases further. And we're exploring the reasons for these results. Is it due to variation in the quality of the address given, or is it the extent of how much it differs from the address-based premium address format, or is it variation in how the given address is recorded? So in summary, the algorithm was found to have a high accurate match rate and has identified and quantified the demographic groups that may be underrepresented among those successfully matched. This is the first time an address matching algorithm has been transparently validated in this way to assess its suitability for address matching NHS patient addresses in GP electronic health records for health data science. This is important so that users of address matching results can be aware of and understand consequent information and selection bias in their analyses and enable confident health data science research. The strengths of this study is that we had trusted access to electronic health records for a whole large geographically defined GP patient population. And the evaluation was not carried out in all UK geographical areas, and London addresses may not be representative of all of the UK. So next steps are to make further revisions and improvements to the algorithm in terms of testing on additional gold standard data, testing in different UK geographical areas, and reducing false positives, which we've made great progress on. We're rerunning the quality assurance in a larger cohort, and we are scaling up into a web service interface, and ultimately we would like to be available for wider use in NHS. And we're now assigning UPRNs to organisational addresses such as care homes to underpin important COVID-19 research at the moment. Thank you. I'd like to acknowledge my colleagues for their contributions to this research, our funders and North East London patients and GPs for trusted access to data. Thank you.
Fantastic, thank you very much. Okay, so we'll move straight on to our third presenter. Associate Professor Pratt is an expert in biostatistical and pharmacological, specialising in development of methodologies to study the effects of medicine and medical devices in linked healthcare data sets. She leads the evaluation of the Australian Government Department of Veterans Affairs Veterans Medicine Advice Therapeutic Education Service Programme, which uses administrative claims data to develop and evaluate interventions to improve the use of medicines in the veteran community in Australia. She's a member of the Drug Utilisation Subcommittee of Australia's Pharmaceutical Benefits Advisory Committee, which assesses estimates on projected usage and financial costs of medicines. So over to you, please.
Excellent. Well, thank you very much, Simon. That was a long introduction to say that I'm a data junkie and a statistician. So I'm very glad to be presenting to you all today. Unfortunately, not in person in my hometown of Adelaide. So hopefully we get to meet again soon. So what I'm going to talk about is a study that we have done around how we can validate the Australian Government Medicare Benefits Schedule data against a large national joint replacement registry data set. Okay, so the Australian Orthopaedic Association National Joint Replacement Registry dataset has been used for nearly 20 years now to monitor post-surgical outcomes of joint arthroplasty, including revision surgery and death. And it contains near complete national data, which represents nearly 98% of all prostheses that are done here in Australia. It has a minimum data set and it's collected at the time of surgery on records directly from the hospital. And that includes things like patient demographics, the surgeon and hospital identification, the procedure that actually occurred, the prostheses that were used in that procedure, every bit of the componentry that is used, including screws and cement and all of the mechanical parts of the joint replacement, and also importantly, the diagnosis or the reason for the procedure. So we wanted to enhance the value of that registry. So we linked the data to two large administrative data sets that we hold here in Australia, the Medicare Benefits Schedule data, which is records of all of the health services that are provided to patients under the scheme, and the pharmaceutical benefits scheme, which has all of the information about medications dispensed to Australian patients. So the data linkage process, we took the National Joint Replacement Registry dataset, which contains procedures that occurred from 1999 up to 2017. And really is a huge data set. So we're talking about over 500,000 procedures of a hip replacement, 650,000 procedures for knee replacements, and nearly 40,000 shoulder replacements. And you can see that patients have multiple procedures that can occur. You have 2 hips and 2 knees and 2 shoulders, for example. So we linked that registry data to the PBS data, so that returned about 468 million records, and the MBS data are about 600 million records. So that linked data asset is contained in a secure unified research environment called SURE, maintained by the Sachs Institute. So it's a cloud-based data repository, and we had quite good data linkage. We had about 95% of all patients matched for hips and 96 for knees and 96 for shoulders. So the objective of the study was to determine the validity of the MBS data for capturing the occurrence of a joint replacement procedure. So we used the registry as the gold standard, and then we determined the sensitivity of the Medicare Benefits Schedule, which collects the billing information for that surgery, incorrectly identifying whether it was a hip or a knee replacement, including the type of hip and knee replacement that occurred. So the way we did that is we identified procedures in the joint replacement registry by type of procedure, so primary conventional hips, for example, and then we identified the MBS specific codes that are specific to that procedure. We did the same for primary surfacing hips, which are actually the same procedure codes, and partial hips, which is half the hip. And then we looked at other MBS codes that are indicative of some sort of procedure happening, like a revision hip, for example, when the hip gets replaced or it fails, or whether there was a hip anaesthetic MBS procedure code, and the same for the knees. So in terms of results, what we have here is the results for total hip replacements that occurred for diagnosis of osteoarthritis. Now, these are generally elective procedures and occur once there is sufficient degeneration of the hip joint and sufficient pain to require a joint replacement. So you can see in terms of our results for a total conventional hip, which is a full hip, including both the femur and the acetabular procedure, about 68% of those are done in private hospital, and around 87% of the resurfacing procedures are done in a private hospital. Now that's really important because the MBS procedure codes are only collected for patients in a private hospital. So we could only do this validation procedure for those patients. So of those patients in a private hospital, we then looked at how many had an in-hospital MBS procedure code of any type on the same day as the procedure date that is registered in the joint replacement registry. And we found about 90% and 93% in the resurfacing hips had at least something on the same day. And of those, about 95% had a total hip MBS procedure code, which was the same as the registry had observed. So in the end, that gives us a sensitivity around 85% of all private hospital admissions had a total hip MBS code and 88% sensitivity for the resurfacing hip. Now, the interesting side effect of this is to really look at misclassification of procedures in the MBS. And what we found is that there were quite a few procedures where there was a MBS procedure code for a hip anaesthetic. So we know that a hip replacement was done, but the total hip code was missing. So that was under counting the occurrence of the total hip replacement. Around 4% of procedures were like that. What we also found was that there was some misclassification of procedure types. So instead of a total hip, there was a total knee or a revision hip instead of a primary hip. So there was some misclassification of procedure types as well. We did the same for the diagnosis of fractured neck of femur. So hip replacement for fractured neck of femur is generally an emergency visit. So these patients may present at hospital after a fall with a fracture of their femur. And as you can see, the results of the number of people we found within a public and private system are quite different than the elective. We tend to have less people presenting and having their hip replacement for fractured neck of femur in a private hospital. So only 40% of all procedures that received a total conventional treatment for a hip fracture in the private hospital were there, and there's much less for the partial hip replacement as well in a private hospital. So of those, we had about 80% of total conventionals that were correctly classified in the registry and the MBS, and lower percents there for the partial hips. For the total hips, we end up with sensitivity around 80%, but for partial hips, the sensitivity is quite a bit lower. So even though there are less procedures happening in the private hospital, many fewer of them have an MBS code that is indicative. And I think that's really got to do with the fact that these are emergency patients, and there is some underrepresentation of what occurs in that hospital visit. Again, we see some misclassification of the procedure type, not so much in the total conventional. There's very few partial treatments identified in the MBS, which are incorrect. For the bipolar procedures, there's quite a high number of people who are actually misclassified as having a total hip. And that really impacts on what we can say using the MBS procedure codes. For total knee replacement, again, we see similar results to what we had for the total hip replacement. Again, these are elective procedures. Around about 68% of them are in private hospital in total knees. Same day in hospital, about 87%, and quite a high sensitivity for those. For unicompartmental knee, a lower sensitivity because there's quite a high misclassification of the partial knees as total knees. I'm going to skip this just to show you that there are differences in the sensitivity across the states, but the sensitivity has increased over time. So in conclusion, we used a validated gold standard data captured by the AOA and JRR, and we identified that the MBS data had a high sensitivity for identifying elective total hips and knees, but 15% couldn't be matched to an MBS procedure code, so they were underrepresented in the MBS data, and around 4% were misclassified. The sensitivity was poor for emergency procedures like fractured neck of femur, particularly where there were a partial hip implant, and there was some misclassification. And the sensitivity again was low for unicompartmental knee, where they were also misclassified as total knees. So the implications, understanding the validity of administrative data is really important when we're trying to use these data to inform clinical practice and policy. And we really need to have a look at the systematic bias that might be inherent in these administrative claims data sets for that purpose. And our results really highlight the importance of maintaining high quality clinical registries in addition to the data linkage add-ons, with the MBS and the PBS data. So thank you.
Thank you very much. Very, very nice. Okay, and our fourth speaker for this session, fourth and last one, but not least, is James Farrow. He's a computer scientist with extensive expertise in developing systems for secure health data management and teaching best practice for software development and programming for epidemiology. For the last 10 years, he has worked in the big health data space, developing the next generation linkage management system for SANT, Data Link, and helping to develop the secure unified research environment, in short. He currently also teaches programming to master's students in epidemiology at Western Sydney, Australia University, and data visualization to master's students at the Centre for Big Data Research in Health at the University of New South Wales. So welcome, James, if you could proceed with your presentation, please.
Thank you. Good morning, day, afternoon, evening, night, whatever particular time zone you're in. I'd like to share with you today some recent changes we've made to our NGLMS linkage management software suite to enhance its functionality and to broaden its applicability and make it easier to adopt into existing workflows and data storage practices. A bit of background. The next generation linkage management system, or NGLMS, is a suite of tools for linkage management which grew out of questions we asked ourselves while doing probabilistic linkage. Why are we repeating so much work? We calculate similarities between records, find and tag related records, and then throw away the details, the very thing we're interested in. What if instead we preserve the relationship data in a computationally accessible form? This opens up a rich world of investigation. We can vary thresholds to evaluate linkage sensitivity, clusters can be extracted on the fly, and we're no longer constrained to a one-size-fits-all data model. Different algorithms can be evaluated without having to recalculate expensive comparisons, and different sizes and types of clusters can use different algorithms, even within a single project. Perhaps a fast mechanism to find superclusters and then a more computationally intensive algorithm to break them down. This paradigm applies equally well to probabilistic and deterministic linkage, as well as different data models, being independent of whether a data spine or ad hoc dataset to dataset matching is used. We built the NGLMS to manage record and link level data in a graph database and to provide tools to manipulate and review the data. This talk describes how this graph-based linkage system has been extended to encompass hybrid storage models to manipulate and review graph-based and non-graph-based data. The resulting system can accommodate and work with legacy relational data, where existing data in relational databases are supplemented with graph-based functionality, or scenarios where all data and cluster management are retained in a relational database. The original NGLMS architecture was quite monolithic. It was designed as a one-stop linkage portal. In practice, however, as I'm sure some of you experienced, portal-based architectures can be somewhat inflexible. They're very good at the things they do, and they can turn into something quite restrictive when you try and move outside that sphere of functionality. To overcome this flexibility, over time, the NGLMS has been refactored into a more loosely coupled architecture to become more of a flexible toolbox of data management functionality and applications. Our review tool is still web-based, which is its original core, but has been uncoupled from the back-end storage paradigm. And I'd invite you to view the on-demand video presentation about the review tool, the NGLMS clerical review tool, NGLMS CR, for more information. This transition has involved moving from a purely graph-based system to a sort of a graph relational hybrid architecture to enable the use of data already stored in relational databases. So the NGLMS can now mix and match its approach to data. On a project-by-project basis, all data may be kept in a graph database. Some data may be kept in a graph database and some in a relational database, or all data may be kept in a relational database. In the NGLMS world, when we work with data, we see a top-level project view consisting of records and their relationships. But this project is composed of discrete layers of information. The record level data, for example, electoral, hospital, employment, educational records, and so on. And the link level data, saying how our records are related and form groups and clusters. And then any sort of meta level data that describes a project structure. And it's structured in exactly this sort of information. We literally refer to the layers that we compose. And so these information layers are first level artifacts in the NGLMS, and we can compose them arbitrarily, which gives us considerable flexibility in comparing different linkages of the same data, or even ad hoc addition and removal of data to and from a project during its lifetime, including link level data. We can swap that in and out as we go. Until now, all the data manipulated by the NGLMS has been stored in a graph database. But this hasn't been ideal when dealing with legacy relational data, because all of that data must be completely copied from the relational storage to the graph storage, which is time consuming. And you can end up in a situation where there are two copies of your data and you need to keep them synchronized, which, as we all know, is a nightmare, and you want to avoid it as much as possible. It would be better if we could leave our relational record data in whatever relational storage system currently manages it, and still retain the ability to form our composite project view, or granting even more flexibility, make the use of a graph database completely optional, store everything in the relational database. I misled a little bit earlier when I said that all data is stored in the graph database. It'd be more true to say that nearly all the data is stored in a graph database. Some of our meta level data has been stored in a relational database. But our latest enhancement has been to allow other data, the record level and link level data, to also be stored relationally. Each of these three classes of data in the NGLMS is handled separately by configurable data managers. And this is what has enabled us to take the mix and match approach to data storage. In our full graph approach, record and link level data are stored in the graph database, but in a hybrid configuration, the record layers can be stored in a relational database and coupled with link layers retained in the graph database. So in this scenario, data layers still in the graph database, still exist in the graph database because links need endpoints, but they're just purely proxies for the full information stored elsewhere. In a relational only configuration, there's no need for a graph database at all. Records only exist in a relational database, and cluster management is performed by manipulating whatever data is stored in the relational database to maintain clusters, whether that's tag records or join tables or whatever. And to complete, we just move all the metadata into the relational database. So our loosely coupled architecture and the REST API that we have made it possible to implement these changes, going from a purely graph-based system to a graph relational hybrid system in about 4 hours. I was quite happy with that because I was the one doing the work. I take this as evidence that the abstractions we chose and that we're using are actually fairly generic and provide functionality for a broadly applicable linkage tool, not just a tool for graph-based linkage. Having this cluster management handled by a separate component meant the transition could be almost entirely achieved by replacing just that component with a relational analog. Nearly all the functionality of our review tool and our basic tools, or the project and data management tools, are retained in the relational only configuration. Functionality which requires a graph representation is unavailable. So, this is a pattern that you get across the system where you need the graph. Advanced functionality which requires the graph isn't possible without a graph. That's the trade-off here. But in such cases, a hybrid approach might be preferable, where you have one and the other working in harmony. Where existing systems and data are in place, the hybrid approach may be easier to adopt than going full graph right at the outset. So, the transition of a live data system into a new data paradigm is an involved task. So it helps to be able to undertake it in stages, and this allows you to do this. And so in terms of adopting this and making a migration, the first step would be to map our data model onto any existing data model. The data model is actually really quite simple. It doesn't really describes the bare minimum it needs to get by. So again, I'd go and recommend going and looking at the online presentation for more detail there. Next, decide whether you want tag-based clustering, graph-based clustering. This will affect your choices of how you do the cluster management, and it'll basically be driven by the level of functionality you desire. And it's something that can be ramped up as you want to do more and more exploration. So for simple review tasks, no graph-based representation may be necessary at all. The entire data backend could be stored in a relational database. For more sophisticated tasks, the link level data can be stored in the graph, while the existing record level data remains in the relational database. So there's no need to migrate all the record level data to a new system. And finally, you create the project descriptions. This is sort of meta level data. And these are, control things like what data sets are involved, who has what permissions, workflow descriptions, OH&S information about the length of work periods to give people warnings they've been working too long, and so on. And all of this information is stored separately to the record and link level data, so it can even be stored in a completely separate system. So we've ended up with a flexible suite of software for the review and manipulation of linked data, which can work on top of graph and legacy relational data stores. It's got a custom UI and workflow aspects that can be configured to use those data stores with very little programming and little to no modification. And you end up with a mix and match approach to data organization. You can integrate it with existing workflows, data management practices, allow gradual exploration and adoption of graph-based algorithms and approaches using data stored in non-graph databases. So I'd like to finish by thanking S&T Data Link for supporting the work, and thank you all for your attention.
Thank you very much, James. Okay, so that brings us to the end of the presentation part, and now we've got about 15 minutes-ish to ask some questions. So if you've got a question I'd like to ask any of our presenters, could you please add it to the Q&A section on the web portal. I would like to thank all the speakers for a great presentation, and indeed for keeping to time. So that made my job almost redundant, so thank you very much. I think there's quite a diversity of presentations here. Kelly talking about consent and the issues around that, Gill about address linkage, Nicole about linking high quality data sets, and James, as always, talking about a subject dear to my heart, really complicated technical stuff. So great diversity. I noticed in the questions, there's a linkage problem in the questions that some of us maybe don't know our own name, so I can't necessarily link the question to the person asked. So forgive me for not calling out your name if I don't do that. So let's look at the data and see what we've got. I guess the first question really is directed to Gill, and I thought Gill's presentation was very good, very interesting indeed. There was a question in the chat about, have you compared your algorithm to the ONS AIMS tool, because there are some similarities. Have you compared the performance of both of the tools?
Yeah, thanks for the question. I think that was from Rachel. Yes, we are starting. Our next step is to compare the quality assurance results with other address matching algorithms, and ONS will definitely be one of them. I'm not familiar with the AIMS tool by that name. We are aware of ONS address matching code that's been available on GitHub. If AIMS is something different, I'd be really interested to know more about that. And Rachel, I might get in touch with you some point today to ask you more about that. But yes, we're definitely going to compare it to other algorithms that are available. Cool.
And I guess I should know this, but I don't. You said the gold standard addresses from Wales. What's gold standard about them, I guess? Why are they gold standard?
Gold standard, it's literally just a data set that's already had UPRNs confidently assigned to them. And that have been manually checked and verified, if you like, so that when we run our algorithm on the same addresses, we can compare our results with the UPRNs that have been already assigned. And it just gives you a check, a kind of benchmark to see if you're achieving the same results, which are assumed to be correct.
Okay. And obviously your algorithm was obviously excellent in many ways, but for very old people living in nursing homes, it seemed to fall just below the bar, which is a bit of a shame for COVID. Is there any explanation for that?
I think for old people, the numbers were quite small. We're not sure why certain age groups at age of registration would be less likely to have a UPRN assigned to them, because in some ways we've got some conflicting evidence that actually the more that you interact with your GP, the more likely you are to get a UPRN assigned, because we think you're more likely to have a good quality address recorded. And I would actually say that for older people, you would think that would be the case. But we think the reason that the odds ratio was lower for the older group, I think it's just that the numbers are very, very small. And I'm not sure we could actually read much into that. But we are doing some further investigation into the results that we find.
Excellent, thank you very much. Okay, so let's move a question on to Kelly. So there's two questions really. There's a fantastic question from the fantastic David Preen and myself combined into one. So I guess my question is consent related to maturity? And David asks, is there a particular age when consent in students drop off sharply, or was a decrease more gradual? Kelly.
So first of all, thank you very much for your questions. In terms of aging and consent levels, so the highest levels were around our year 7 pupils, so our age 11 to 12, and the lowest consent rates were amongst our year 11 pupils, so around our 15 to 16-year-olds. And there was a general trend that the older the children got, the lower the consent levels became. So that's the first question. And then the second question around perhaps reasons why, it could well be due to maybe older children taking part in the more risky behaviours, or being able to perhaps, in terms of the smoking, the cannabis use, and their willingness almost to share those details with us, knowing that we're also asking for personal identifiers as well. But it's worth noting that compared to our previous rounds of the survey, we didn't see any differences in the level of risky behaviours reported. So it doesn't seem that introducing consent to linkage is affecting young people's willingness to share details with us.
Okay, James, I guess I had a similar question to Mr. Martiz, in the fact that, like, what graph database have you chosen to use for yourself?
We initially started with Neo4j. Found that the development of Neo4j sort of lagged for quite a while to give us the functionality we want. So we moved to DataStax, which is basically built on top of a Cassandra cluster. Has some quite nice tools there for managing that. But I would say it's about 95% independent. Most of the manipulation of the data and the querying the data is actually all written in Gremlin. So there's a very small amount of dependency on the way DSE handles its schemas that is really tying it to that. I would really like to sort of remove that altogether, so that, you know, if you wanted to use something like AWS Neptune, you could connect it up to that, because it's using a sort of, it'd be like using Gremlin's a bit like SQL. You use a standard query language for talking to graphs, and you'd be a bit more independent in that regard.
So I guess a question from myself, if I may dare. I think the mix and match of relational and graph database seem to vary between them. I know obviously you're completely agnostic in some ways, which is interesting. I would have expected perhaps more graph database because of the fact they can horizontally scale, and I guess graph is a first class concept in your algorithms. Why? I guess you talked about the data duplication, which is annoying but solvable. Why bother with relational, really?
It is a question. I think it's because of if you want to adopt it, you don't really want to go through that phase if you've got a lot of data where you have to do that sort of big sort of swallow of the database paradigm where you want to move everything across. This will let you keep a lot of your workflows, a lot of your data paradigms that you're already used to working with, and you can experiment with the graph on top to see how it goes. And if you don't like it, you can just go back to the old way, because you haven't actually changed your underlying data. You haven't had to reformat it or develop new data models. You've built it on top of it. So it's really to aid in that transition. I don't see it as an end in itself. I see it as a stepping stone.
Okay, thank you very much. A question for Nicole. Nicole, do you have any ideas for the MBS misclassification? Did the misclassification change over time? And that's from Derek Lopez.
Yeah, that's a great question and something I will be looking into. But I think in terms of the reason for the misclassification, I think it really is just as easy as a partial hip replacement being misclassified as a total hip replacement, and the same for the unicompartmental knee, which is a half a knee, being misclassified as a total knee. And of course, there's different costs involved in all of that. So in terms of the change over time in the misclassification, I haven't actually done that, but I did see that the overall sensitivity has increased over time. So it'll be interesting to see whether that misclassification has changed. What you wouldn't have seen, because I sort of flipped through it, is that the misclassification sort of does differ across the states, and another area sort of really to understand why that occurs in the systems that we have in Australia.
Okay. Maybe I misunderstood because I'm not as clever as you, but it's kind of like the difference between an emergency admission and a planned admission. Why would an emergency admission lead to less data quality? Surely the same aspects to collect.
Yeah, look, it's a good question, and something I really need to talk to the surgeons about at the coalface at the hospital, and what are they actually billing for. It's more a problem about the missing codes rather than a misclassification in the emergency, and it might just be, you know, the timing of that procedure. So it's something that I think I need to go back to the clinicians and really understand the process.
Thank you very much. Okay, and we've got time for a few more questions. So if you want to put them in the Q&A, we can give our speakers a hard time, which is always the best part of the conference. Can we go back to Kelly? Let's see if we can give Kelly a hard time. So there's a couple of questions there about the linkage quality. So there's a question of were the bias in students who were incorrectly linked, were they linked to the wrong person, or should they have not been linked? And I guess there's a related question saying that linkage rates seem very low, even though pure deterministic linkage. Why was this? Did you undertake some kind of clerical review? Sorry, similar questions.
Can you remind me of the first part of that question?
Yeah,
sorry.
so it's kind of, no, absolutely. Was the bias in students who were incorrectly linked, were they linked to the wrong person, or should they have not been linked at all?
Mm-hmm. So in terms of a linkage, there wasn't so much incorrect linkage, there was just unsuccessful linkage. So we only know at this point the percentage who were or weren't. And in terms of why we couldn't link some, so yes, we did ask for names, so that was pretty straightforward, it seemed. But when it came to dates of births, we ran some simple parameters around knowing children should be between age 11 to 17, and actually it was more the postcode data which was inaccurate. So some children were providing the first 3 or 4 digits and not the whole 7 digits. And actually some, even though they were consenting to linkage, they were providing more text options and giving their opinion on perhaps wider issues than actually giving the data we were asking for. So for our next round of data collection, we have introduced more constraints around the type of text that can be used and provided, and to hopefully increase linkage quality going forward.
That's good. Although I know the answer, let's ask the question anyway. Did you undertake much clerical review of the linkage process? And the answer.
Sorry.
Did you undertake much clerical review of the linkage process?
No, so we use a third party to take the identifiable information, and then the linkage itself is handled by a team within the Sale Data Bank.
The answer to that one, but it's not my turn. So that's very good. Are there any other questions that from the audience at all? No? Then I'd just like to take the opportunity to thank our speakers today, who I think have been absolutely terrific. Been very clear presentations and a very interesting subject. So on behalf of the conference, on behalf of myself, thank you very much. And we just draw this session to a close. This session is recorded, and I believe it's 24 to 48 hours afterwards. It's available on the portal. So if you want to catch up on any detail, and obviously, please reach out to any of the speakers and ask questions offline. I'm sure they would love to hear from everybody. So thank you very much, everybody, for joining this session, and enjoy the rest of the conference. Goodbye.
Thank you.
Thanks very much, Simon.
Take care.
Simon.
Thanks, Simon. Bye, everyone.
Bye.